This time we have the pleasure to have him in person. Lorenzo, in our behalf, thank you a lot for accepting our invitation. The floor is yours.
Thanks a lot. Now I'm moving because I need to start my presentation. So first of all, it's a pleasure to stay here with you in this wonderful country and with a lot of friends, also some Italian friends. So from Pavia, it's important because there is a continuous exchange of specialty between Lisbon and Pavia, between me and Joao, and not only because we are also together in the European Reference Network Reconnect. So we have a lot of job that we can do. The title of my speech today is The Anatomy of CPK, because this is a laboratory instrument that we can use and we are using a lot, but we could have some problem in the interpretation of these results. It is important as a starting point to know what is CPK. First of all, is an enzyme. For sure, we know that this is an enzyme. It is used to convert creatinine to phosphocreatinine, allowing the production of energy for muscle. So this is very, very important for our muscle activity, in particular during high energy demand periods. So when we are running a lot, we are using a lot CPK. But we know also that we have different isotype of CPK. We have, for example, to CPK that may arise from brain, from muscle, from heart, but not only. We can have also CPK from mitochondria. But the question is, as a clinician, do we care of CK isotypes? This is the answer. We don't need to fulfill more depth information about the subtypes of CPK. For us, is enough the normal CPK. We have also another problem, another condition that should be considered, that is the concept of Gaussian distribution of the normality. All these values of CPK are normal. This is the distribution of the normality in healthy people. But we have also another issue that is addressed to normal limit according to laboratory limits, because we have some patients that are participating in this 2.5% of people that, despite being normal, the values are much higher, might be much higher with respect to the normal value of the laboratory reference value. So this is a problem because these people is normal from both the left and the right. Maybe that someone has a CPK very low, this is not a problem for us, but someone normal, healthy people may have an increased level of CPK. We should consider also that we may have different influences in terms of ethnicity. For example, Black people are usually presenting with higher level of CPK, being both males or females with respect to Caucasian, but also to Hispanic people. So there is a genetic difference, ethnicity difference according to this normal value, value in normal people. We have also other difference in terms of activity. For example, in Black people, CPK activity is very, very increased with respect to Caucasian people, and in particular, as you can see here, in muscle and in iliopsoas. This is very important because this may explain some of the strength aspects in terms of athletic tournament, in terms of 100-meter plan, because for sure, we as a Caucasian, we are not so fast as Black people, and CPK may allow this performance, this increased performance of Black people. But if this study is confirming that ethnicity may be important, we should consider that we may have also other confounding factor. Remember, CPK is substantially lower in older men with respect to young men. This may be due to several factors, maybe to the muscle wasting that could occur in older people, but it's important to remember that we should also consider body mass index as an indicator of CPK, because people with low body mass index were less likely to have elevated levels of CPK. On the contrary, overweighted or obese people may have increased level of CPK, at least almost twofold greater. So it's important to observe the patient from the beginning, in terms of ethnicity, in terms of sex, in terms of body mass index. But we have also another issue that should be considered. This was very famous in the past. In the early 18th, there is a lot of debate about macroenzyme of CPK. Now we forgot it for sure, because it's not normal to consider the possibility that we could have a macroenzyme, but CPK may be also a macroenzyme. With the normal available tests, we cannot rule out if we have a CPK of normal dimension or a macroenzyme. But from the clinical point of view, if you consider these 2 points, the macro CK1 and macro CK2, you can understand that irrespectively to the occurrence of a macroenzyme or normal enzyme, we could perform a differential diagnosis in terms of identification of autoimmune diseases for macro CK1 and even for malignant cell proliferation for macro CK2. But what we are doing normally when we have one patient with increased CPK without having a previous diagnosis, we always think to a possible overlap, autoimmune disease as a rheumatologist, and we also think to the possibility to have an underlying cancer. So we are doing exactly what this slide is supposing to allow to be performed in terms of analysis. Remember that we may have a macro CK1 is the association of CKs enzymes with the immunoglobulins, and this is an oligomeric complex of CPK. But with our laboratory normal test, we cannot rule out if we have a macroenzyme or not. Remember, also alanine transferase may be present as a macroenzyme. This could be useful. This is a list of conditions that might lead to an increase in CPK. As you can see, we may have different conditions. We have genetic muscle disorder. We have also neurological problems. We have metabolic myopathies, endocrine disorders, hydroelectrolytic disorder, and so on, including infection. But if you can see the number of conditions that are included in this chapter, we have a lot of things that when we are assessing one patient with CPK, increased CPK, we should consider. We should consider the possibility that the patient has nothing, for example, might be that she is very active from the physical point of view. We might think that he could have also genetic problems such as limb-girdle dystrophy and so on. But as a rheumatology, I suppose that when we are looking at one patient with increased levels of CPK, our first thought is maybe that this patient could have an idiopathic inflammatory myopathy. Idiopathic inflammatory myopathy, as you know, may include different conditions that are no more limited to classic polymyositis and dermatomyositis. Now we have antisynthetase syndrome, necrotizing myopathies, overlap myositis that are steadily increasing in terms of interest and numbers, cancer-associated myopathy, hypomyopathic form of the disease, but we have also IPAF, because you know that IPAF patient may have ILD, and they may have anti-Jo1, they are antisynthetase syndrome for sure, but also anti-SCL70, anti-RMP, and so on, a lot of autoantibodies. This condition may be related to IPA spectrum disorder, and this could be included someone in the spectrum of idiopathic inflammatory diseases, other in the spectrum of systemic sclerosis. We have also IBM, but as I told to João yesterday, this is a disease only for neurologists. Isn't true. We are looking every day also IBM patient, but we need the support of neurologists, in particular for this condition. You know that we have myositis-specific autoantibodies. They changed completely our approach to myositis, starting from antigen-1 that were the first described, but now we have other anti-synthetase antibodies. We have anti-Me2, we have anti-SAE, as previously presented by you with the case of the first case I saw. We have anti-MDI5 antibodies. I'm expecting a lot of questions about anti-MDI5 antibodies at the end of the presentation, SRP, and also antibody that may be related to necrotizing myopathy, such as HMGCR, that are associated with the use of statins. We have also these latter autoantibodies, anti-CN1A, that is strictly not sure related to inclusion body myositis, but we have myositis specific and also associated antibodies that could support us in the assessment of patient, because we have a lot of conditions referring to myositis spectrum disorder because we performed a clinical serological correlate between autoantibodies and diagnosis. So, for example, generally, people presenting with anti-synthetase antibodies and findings that could be included in the spectrum of myositis symptoms are diagnosed with anti-synthetase. We have these antibodies that are associated with necrotizing myopathy, and so on. We are used to perform a clinical serological correlation between autoantibodies and diagnosis. But we could have a problem, and we will see later. But the starting point is which level of CPK should be considered not good. There is no consensus, first of all. Maybe that someone in this paper that has been published in 2010, hypercapemia 1.5 time upper than normal levels could be considered pathological, or at least you could perform additional testing if this level is increased, if the increase is more than 1.5 times. This is the minimum level we could consider. But sometimes, for example, in the classification criteria of anti-synthetase syndrome, the entry criteria for CPK, it's twice, it's not 1.5. This could be discussed, but as you can see, the level of recommendation is very, very low, is C. So we should discuss about that, even considering what I previously showed to you, that normality is only a definition and is not always normal, the definition of normality. What's the future of people that is presenting to us with pouchy or asymptomatic hypercapemia? You can see that in a lot of patients, we are not finding a diagnosis or a problem. To 29% of people is normal. Maybe that sometimes we could have a neurogenic condition that is underlying to increase of CPK. Maybe that we could found non-specific myopathy, so we are unaware completely about the underlying disease. And we have specific myopathies is into 26%. Mainly inflammatory myopathies, muscle dystrophies, miscellaneous, and in particular also a great number of metabolic myopathies. So you should consider it when we are looking at one patient with an increased level of CPK. It's easiest that the diagnosis is not myositis, but could be another diagnosis or not diagnosis at all. Starting point, please observe as a male or female, because you should remember that inclusion body myositis is more common in male, whereas other forms of myositis are more common in females. The weight, because high BMI, higher risk of high CPK, and then the age. because people with EBM are generally older with respect to other patients with other conditions. So this is the first point to be addressed. Then we should always ask for personal behavior, as for example, alcohol consumption, drug use or abuse, both licit and illicit. For example, cocaine may be a leading cause of increase of CPK, not only of vasculitis-like problems, but also increase of CPK. The use of statins also should be considered with different caveat that I'll present you later. Corticosteroids, because we have also an induced steroid myopathy. And also checkpoint inhibitor. This is a raising problem because checkpoint inhibitor are important in our daily practice, but they can lead to the occurrence of different rheumatologic problems. Also myositis, also interstitial lung disease for sure, but we have more evidence about the possible occurrence of muscle involvement. But please see this last point, anesthetics used for general anesthesia, such as, for example, in particular, Allothane. This is a problem because some people is at increased risk to have malignant hyperthermia. That is a very, very dangerous condition that have some genetic basis that may hit people with after an anesthetic, after the use of anesthetic gases such as Allothane. The problem is important. It's a rare condition, but it's very, very new by our intensive care unit specialist and before any surgery intervention, anesthetician are asking for the familiarity about this problem because we may have respiratory problem, respiratory acidosis, cardiac involvement. We have muscle rigidity and muscle breakdown. We have obviously hyperthermia, but we have also other problems. And these patients are at increased risk of death. But we have the possibility to use therapies such as dandrolene, but that is a well-established drug that is well working in this patient. But the suspect is absolutely necessary. But we have also other problems. This is a patient that performed allogeneic stem cell transplantation 4 years ago that was admitted in our unit. And he presented with muscle pain, high levels of CPK, and see the dimension of this arm. It was very big, really. This was a problem that was related to rejection of allogenic stem cell. It was a chronic rejection with an acute phase. The patient improved after corticosteroid therapy, but we should consider also the possibility that we could have a CPK increase also in terms of organ rejection, in particular hematologic, but also lung. Then we should search for non-disease related condition, trauma, injuries, activities, for example, sport or job, and intramuscular therapies that may lead to a strong increase in CPK level. But we should also search for non-muscle related disorders. We have one example. I think that you know Andre the Giant, at least the older people for sure can know this wrestler that was very famous in early 18. He was affected by acromegaly. And acromegaly is a condition that is a risk to have an increased CPK level. But for sure, the most common causes in terms of endocrinological problems are hyperthyroidism and hypothyroidism. We may have different symptoms with one that is common, that is air loss. You know perfectly that people with hyperthyroidism might present goiter, heart palpitation, tremors, low-degree fever, diarrhea. So take care of all these symptoms because in the majority of cases, an increase of CPK is related to hyperthyroidism or hypothyroidism. This is the most frequent cause of disease that you should deal with, and think when you have a man or a girl with a CPK increase in terms of epidemiology, really. Then we should search also for other non-muscle related disorder, and infection might be very important. For example, if you have a patient with hypercipicapemia and hypereosinophilia, previous diarrhea, abdominal pain and vomiting, and also with the extraenteral symptoms such as edema, myalgias, and skin rashes, think always to trichinella. CPK in increased hypereosinophilia start to suspect, maybe a trichinella infection. Is not so rare. We observe some patients with this underlying cause of CPK increase. Muscle biopsy in this patient could be useful, but also serology could be useful. In this case, we need the partnership of our infectious disease specialists. But always remember, hypereosinophilia and CPK, okay, it might be trichinella. But we could have also other problems, other infectious problems. We could have a lot of virus that could lead to myopathy, for example, COVID-19, for sure, in particular myocarditis, but only muscle involvement, peripheral muscle involvement. We have parvovirus B19, Coxsackie virus, human enterovirus, and so on. We have other conditions such as trypanosoma cruzi infection. We could have some patient with pyomyositis, very rare, very, very rare. And we should consider in particular that virus may be an important cause of increase of CPK. And in particular, they may be involved in virus myocarditis, viral myocarditis. That is always a possibility we should consider when we are called in intensive care unit or in cardiology looking at one patient with myocarditis. The toxicity of virus might be direct or might be related to an immune response. We have also other possibilities, but the first two are the most common one. So remember always that parvovirus B19 may be a cause of different rheumatic problems, not limited to myositis, but addressed to everything, lupus, rheumatoid arthritis, and so on. But the most important thing that we should do is physical examination. We should check heart rate, thyroid enlargement, the occurrence of skin lesion, peripheral lymphadenopathy, lung recalls, and also diaphragm mobility that we can assess easily when we are visiting the patient. We don't need some X-ray, we need our hands to define if a diaphragm has a normal motility or not. Now we should look for a possible myositis. We have different skin signs that you know perfectly. We have also joint involvement. We may have dysphagia. We should discuss about dysphagia, but also muscle and lung involvement. Muscle involvement is not mandatory to have a myositis, remember, because as I told you, really in terms of IPAF, we could have a lot of patients with that could be classified inside the spectrum of myositis disorder that is without muscle involvement and also without CPK increase. This is a renal phenomenon. You know it perfectly. You know also perfectly that when we are asking to a patient if he or she has a renal phenomenon, we may have a lot of answers completely wrong. You need to show a picture, this one. Please observe. No, okay, I was wrong. Isn't true. It's most very, very transversal, assigned to different connective tissue disorders, but not only, because we have the main problem where we are looking at one patient with renal phenomenon is quite Danish question. Is primary or secondary? Is primary or secondary? But we could have the answer by observing some particular aspect. Please remember, the primary renal phenomenon is not only induced by cold, but also by stress. It's very, very frequent in young female teenagers. Few daily episodes without distal ulcer and mainly bilateral. Pain is very, very rare. It's not frequently painful. This is important to remember. At the opposite, secondary Raynaud phenomenon is not induced by stress, mainly patient older than 30 years, more daily episode, frequently is not bilateral, is not symmetrical, is asymmetrical. It's very, very painful, and this ulcer might appear. Every Raynaud phenomenon with ulceration is not a primary Raynaud phenomenon. This is the golden rule that you should consider in these patients. But we have rheumatological causes, and you know what causes, but we should consider we could have different causes that should be explained. And this is a list of possible problems. But from the general point of view, when you are looking at one patient with Raynaud phenomenon, take care of patient age and sex. Does the stress lead to Raynaud phenomenon occurrence? Check for style life, because smoke is another cause of Raynaud phenomenon. If a smoker may have a Raynaud phenomenon, and ask for it. And before start a treatment, first of all, ask for stop smoking. This is very important. You should consider also patient work, because jackhammer may have a Raynaud phenomenon for vibration. It's not a rare cause. This is important. We should consider if the patient started beta blockers, because beta blockers may have a peripheral vasoconstriction and might lead to the occurrence of Raynaud phenomenon. We should exclude the thoracic outlet syndrome. That is not so rare, not at all. In particular, also in young people is very, very common. But the most important point as a rheumatologist is that we should perform NAFO video capillaroscopy, at least a baseline autoimmunity. This is NAFO capillaroscopy. You know what is NAFO capillaroscopy. You know why it's so similar to this very, very strange object. This is very strange also for me. I have no idea about the translation of this one, but no idea, really. But this is a normal aspect of NAFO video capillaroscopy, but we should search on different abnormalities that I'm resuming here. So we should search for megacapillaries, microhemorrhages, avascular areas, Buabashi capillaries, and this is the typical aspect that may be observed in patients with myositis. We may have a scleroderma-like pattern. We did not define it again, myositis pattern in capillaroscopy, but I think that we will do. But I think that you are doing every day the assessment on NAFO video capillaroscopy. We should look at skin. We should look at skin. We should search for mechanic hands. We should search for ICAS fix. That is the corresponding of mechanic hands in feet. We should also look at Gottron papules and sign. Gottron papules may be of different redness. Is not mandatory that are fully red. There may be different escalation of the color. We have also Gottron sign, but sometimes Gottron sign could be not easy to be diagnosed, because I suppose that in the majority of cases, if you are calling this lesion psoriasis, you're right, for sure, the majority of cases. But this patient had also mechanic hands, and anti-MDFI antibody positivity also. So be careful, because psoriasis is not always psoriasis. Check it. In terms of biopsy results, there is not so huge difference between findings I can observe in psoriasis and in myositis. So it is very tricky. We should analyze this possibility, but be careful. Then we can see also heliotroporesh. Remember that sometimes heliotroporesh may be hidden, really, and present and observed only if you are raising the Yelidis for sure. And it's important to observe that we may have also a periorbital edema. We have a lot of other possible rash that could be described. This is an association between lesion that we can observe. This is a patient with anti-TIF1 gamma positivity. We may have also telangiectasia, Oster sign, and so on. And remember also calcinosis. Muscle involvement is typically more common in myositis in proximal muscles. We may have also involvement of distal muscle, but is more intense with respect to proximal muscle. If we have a predominance of distal involvement, we may search and think to a possible inclusion body myositis. We should perform the analysis of the strength of this patient through the MMT8 that is reported here. We may have 8 muscle groups that could be assessed, 7 bilateral and only one, that is the cervical part, the neck flexor. And we have 150 as a maximum point that we could reach for these patients. Obviously, we can be 150 because we may have O, no contraction, and 10 normal strength. This should be remembered. But we have also other muscle enzymes. For example, we should consider that transaminases, LDH, troponin, and also aldolase may be increased. In particular, remember that the 10–15% of people with myositis may have not CPK increase, but they could have aldolase, unisolated aldolase increase, in particular in painful condition, because aldolase are near to the fascia of muscle, and we have nociceptors that are in the fascia. So painful myositis may have an aldolase increase of the aldolase and not of CPK. I think that it's better to evaluate both enzymes, and then after the first result, you should identify which will be your biomarker for the future, generally CPK. Then we have dysphagia, and we have a problem with dysphagia because we have not a clear definition of the tools we should use to define dysphagia. Might be that I could ask to a patient if he's facing some problems. Might be that I could perform electrodiagnostic tests. It's not easy to be performed. Might be that I could ask for a fibrotic endoscopic evaluation of cell wing. Might be that I could ask to scintigraphy, to MRI, but there is no agreement in the medical community about the tool that should be used. We are generally using fiber optic endoscopy in our center because we have a very, very strong specialist. Then remember arthritis. Arthritis is a common manifestation of myositis patient. We could have both an involvement that could be similar to those observed in rheumatoid arthritis in terms of clinical presentation and radiographic presentation, but we may have also findings similar to Jacques arthritis that is reversible. You know it for sure. But we have also another big problem. So this is the reason why when you have one patient with CPK increase, you should check the lungs, because we may have an underlying interstitial lung disease. Lesions are starting from the basis, subpleural, and raising up during the time. This is the normal evolution of all CTD-related ILD. It's very important for us to visit always the patient in the lungs. We may have an NSIP presentation, UIP presentation, organizing pneumonia, and very, very rarely also diffuse alveolar damage. This is a typical aspect of patient with UIP that is characterized by an heterogeneous presentation of lesions. We may have normal lung, we may have alveolitis, we may have fibrosis. So there is heterogeneity that is quite opposite of SNIP, where homogeneity of lesion is the rule, both fibrotic or inflammatory or cellular. OP is It's this one. I think that you know it, in particular after COVID-19, we saw a lot of people in intensive care unit presenting with OP, and we were asked a lot for consultation and this patient because it's very, very similar to the presentation we have in our anti-MDI5 patients. Some words about immune-mediated necrotizing myopathy that are generally seropositive with SRP and HMJCR, but sometimes they are negative, but there is a very poor clinical description. You should consider that in terms of studies, we have the nocebo effect. This is very important. Nocebo effect is the opposite of placebo. I'm taking a placebo, oh, it's well working, I'm still feeling better than before. Nocebo effect, if the drug has no problem, I'm taking this pill, I think that you will be bad for me. This is the typical behavior of people that is assuming statins, really. So the prevalence of statin-associated myalgia is much higher in observational study with respect to blinded randomized controlled trials. So we have a problem of nocebo effect. Myopathy is rare. And the rhabdomyolysis that is very, very hard to be treated is a serious problem, is much rarer also with respect to myopathy. Some sign, remember, it's very common that we could have a statin-related problem if the problem is bilateral and non-unilateral, if it's involving large muscle groups, if it's involving also it's associated with pain. The timing of onset is generally in the first phases after statin starting or change of dosage. Otherwise, we could have other problems. We could suppose other problems. No, there is not a statin-related effect. We may have sometimes not so elevated CPK level. We have also other considerations that are clearly resumed in this part. So which patient is at increased risk to have side effects of statins? Female gender, old age, lower body mass index, Asian ethnicity, hypothyroidism, low vitamin D levels, diabetes, renal, and so on. But please see and observe heavy exercise and major surgery. These could be stressful events that could lead to the occurrence of the side effects of statins. We have also steroid myopathy. Steroid myopathy is important in our daily practice because sometimes we are treating people with myositis that is at the beginning feeling better with corticosteroid and then the problem come back. And we are increasing steroids and the problem increase again. This is because with high dose of corticosteroid, we have the risk of this side effect. Remember that CPK level might be slightly increased. The improvement is with the reduction of corticosteroid. Electromyography and MRI are generally negative, for sure. And if you are performing a muscle biopsy, you could identify a selective atrophy of type 2 muscle fibers. Obviously, look at catching features. This is important because low level of corticosteroid, 5 milligrams of prednisone, are not generally associated with an increased risk of steroid myopathy. These patients are quite always a catching aspect. And check for neck flexor weakness. When present, generally the problem is an active myositis. But we have also different non-inflammatory muscle disorder. There is a lot of things that we can do, but please observe these images. We have a facioscapulohumeral dystrophy on the left. We have the beaver sign, that is this one. It's not working well, but you have the original slides, so you can check it. You should observe that we have abnormal movement of umbilicus upward with respect to contraction of belly muscle. And then we have also, trying to do again. See, this is typical of scapulohumeral dystrophy. We have also myotonic dystrophy. We're presenting with only drop head, and we have a limb girdle muscular dystrophy. Check out this young patient is raising up. She's using hands. She cannot raise up, live up. Take care of this aspect, really. Then we should consider also late onset Pompe disease, in particular if we have a late onset, and in particular if we have also involvement of diaphragm. This is important as a condition, is not so common, but is a possibility. And this is the distribution of muscle strength deficit that we could observe. Please see this patient, how she is moving. She cannot live up. Legs are okay, but no, it's not working, sorry. Okay, we have also another sign that could be useful, that is abdominal preeminence not corresponding to patient BMI. This is because these muscles are weak, are very, very weak. We have also the Gower sign, and all these findings, you should check for it when you are looking at one patient despite the age with an increased CPK, because they are clearly established. However, if you have doubt, you can ask for dried blood spot or perform a muscle biopsy. Some problems, clinical serological correlates for sure are important, but remember, antibodies might be false positive and false negative. This has been reported for anti-NXP2 antibodies, in particular in the case of multiple positivity, but we performed also this study, and we may have not for anti-G1. You should trust anti-G1 because it's a very, very excellent result. You should be confident in the positivity of anti-G1, but PL7 and PL12 and other antisynthetase antibodies and not only might be false positive. You should also trust to anti-MDA5 positivity. There is not a so high risk of false positivity. The last point is that sometimes we should also think to different conditions, and in particular, maybe that we should think also to sarcoid myopathy. It's not so rare to occurrence of sarcoidosis with antisynthetase syndrome. We identify a lot of patients in our cohort, and also in other colleagues talk to me because they were completely worried about the occurrence of both sarcoidosis and antisynthetase syndrome, but this is a possibility. Biopsy is important also to occurrence of some changes in muscle MRI that may be focal. Please check it and remember that also sarcoidosis may lead to an increase of CPK. This is my last slide. When you are looking at one patient with CPK increase, we should be careful about the extent of the increase, first of all, the ethnicity, the sex, the age and BMI of the patient, the habits of the patient, physical activity, to treatment, ongoing or previous, other laboratory changes and accompanying features. This is what we should do when we are dealing with a man or a girl, a patient with a CPK increase. This is our job. Thanks a lot. Slides on your full availability for all of you without problems. Use it as you wish without problems. Veronica?
So it's literally two questions. One is one question that we got asked several times. If you receive a new myositis patient or a suspicion of a myositis patient, a classic at least, and you performed the myositis blood and you came with more than one myositis specific antibody positive, which is usually your approach in these situations. How do you interpret this situation?
So it's a wonderful question because it's not so rare that we could have a double positivity and more than double sometime. we have analyzed the cohort of the class project and we finished a manuscript, and that information that I can share with you is that if you have a multiple positivity that is including anti-synthetase antibody, generally anti-synthetase antibodies rule to clinical presentation. Then, in case that you have not the anti-synthetase antibodies, check the degree of positivity, that because it is possible that someone might be weak positive and other strong positive. You should trust to strong positive. Then, maybe that sometimes you could find, for example, in intensive care unit, patient that is positive, weak positive for anti-MDI5 and might be positive for anti-Me2. I think that in this case, anti-MDI5, despite the rule I previously said to you, may lead to clinical judgment, because the clinical is the most important thing that could allow the classification, the identification of the truth of the antibody result you are observing. But first of all, anti-synthetase leads, and to the higher titer generate lead. This is the answer I could say right now.
That's what we do usually as well. The problem is when we have two strong positives, what we do in this situation, especially if it's a dermatomyositis. The other question is regarding the CK and the aldolase. It's quite common to receive new patients on a first appointment coming for a suspicion again of myositis with myalgia and like normal CK and high aldolase. Usually, what do you do in these situations?
Generally, I'm always asking for both laboratory results. If you have CPK normal and aldolase increased, and we have a clinical diagnosis that you trust, so for you is myositis, one of the condition in the spectrum of myositis, I use aldolase as a marker of disease activity in the future without considering CPK. If we have CPK, I prefer this because it's less expensive with respect to aldolase. And in this patient, it's also useful to check the pain, because as I told you before, aldolase increase is strongly associated with muscle pain, myalgias. So if pain is improving, you could be confident that the disease is improving also. If you are talking about muscle biopsy, also you are wishing when we perform a muscle biopsy in a patient with aldolase and not CPK, generally we are looking always lab results. In case of autoantibody positivity, myositis-specific antibodies positivity, MRI that is consistent with the suspect, a clinical that is consistent, we are not performing muscle biopsy, only when we are aware about the diagnosis.
Hi, Lorenzo. Thank you very much for a wonderful talk, as usual. So my question is, the myositis induced by statins. So when you have a patient that you have a strong possibility of statin-induced myositis, but he is like post-stroke, so he really has to do some statins, or post-myocardial infarction. So what do you do first? Can you cycle statins, so you go from one type of statin to another, or reduce dose? My first question, because I always ask Raquel this question, or do you change for something else? Because I know there are some new treatments. Can you just elaborate on that? Thank you.
We are changing the target. We are using biological drugs that are now available, and we can switch to these drugs. Yes, we have biotechnological drugs that are currently used by our cardiologists, and we are changing or directly change. Because also ezetimibe might have some side effects. It is also possible to change the statin, because, for example, rosuvastatin may be more useful with respect to simvastatin. But generally, in these cases, I prefer to change the target. It's not my prescription. We use it in Tekavir, but it's job of our cardiologist. It's in the hands of our cardiologist. I don't know, it depends. Maybe it's one or the other. I no idea. It's your job, job of my cardiologist.
You showed us a concern that we all have when we have CK that is elevated, and after sorting everything out, mainly clinical manifestations, etc., we just conclude that the patient has raised CK with no possible explanation, and then below that we can have the micro CK that is associated with cancer. So of course, if we have any kinds of clinical manifestation, we will investigate that as much as we can because we raise the suspicion of a cancer. But the problem is to have patients with referred to us with a high CK with nothing. So how much, in your experience, should we invest in additional examinations that are sorting out, in fact, cancer? So do you have that type of concern or not?
A lot of concerns it is people, because it's not easy to plan to follow up, for sure. Generally, we are repeating after 6 months and 1 year the assessment, also in terms of laboratory autoimmunity. We are, in case of risk factor, we are performing cancer screening for sure, but we are looking at the patient, for example, young male, not at all, but an old man, okay, I should check it. But we have not the answer because we don't know. We don't know really. It's a huge problem.
My question comes in line with the professor's question. How long do you keep these patients in follow-up? Say it's the typical patient is middle-aged, not too old, not too young, or yeah, CPK elevated, no specific clinics. We can't find really anything, maybe a bit of fibromyalgia.
After the screening, after having repeated the screening in the first 1 or 2 years, depending on patient type, yes, it depends from patient type. Older people, maybe also 3 years. Then my follow-up is once a year. It's once a year. Without additional testing or then in case of new symptoms or new problems.
Thank you for your excellent talk. I was wondering if you could comment a bit on the role of electromyography in the assessment of these patients when you have elevated CK, and especially when we have involvement of like cervical muscles, for instance, which I think are difficult to assess.
I didn't report the information about testing of this patient. I saw some, I talked a little bit about muscle MRI, but electromyography is very, very important. As we could perform also electromyography of neck flexor. It's very, very important, but you should be confident with your neurologist. That should be very, very skilled interpretation of findings. It's because generally neurologists are very good at analyzing peripheral nerve problems and not muscle. So it's important to have a training, to have a figure you can discuss about the findings you are looking for. This is important, but for sure, electromyography is mandatory in all patients. And even MRI, if you have the possibilities, better to perform also MRI. Obrigado. Grazie. Grazie a tutti.